So the pharmacodynamics of the IV anesthetics. Actually, I'm going to talk about the pharmacodynamics of the IV anesthetics separately for each drug, okay? But this video is just to give a general idea about the pharmacodynamics of the IV anesthetics, or to talk about the general features that most IV anesthetics share in common terms of pharmacodynamics, okay? And always remember that pharmacodynamics is the effect of a drug on the body, and the pharmacokinetics is the effect of the body on the drug. The D here may remind you with that, okay? So the effect of a drug on the body. So let's get started. Let's assume this is my syringe, and the green thing here is the IV anesthetics I'm going to give, and I'm just pushing the syringe against the patient veins in his arm. What is the effect of the IV anesthetics on the venous system? Actually, most of the IV anesthetics increase the diameter of the veins. They dilate the veins, okay? They increase the capacitance of the venous system in the body. So increasing the diameter of the veins or venodilation will decrease the preload or decrease the blood that is returning to the heart, because you have the same amount of blood and you are dilating the veins, okay? So the preload to the heart will decrease. So let's move on. This is the IV anesthetic moving from the veins into the right atrium through the superior inferior vena cava. This is the right atrium of the heart. This is the tricuspid valve and the right ventricle. Okay, so what is the direct effect of the IV anesthetics on the heart? The first thing that IV anesthetics has minimal direct cardiodepressant effect, okay? So the hypotension when you give IV anesthetic is mostly due to the venodilation, not due to the direct cardiovascular depression, okay? So you venodilated this patient, his blood pressure will decrease, okay? And the heart will try to increase the heart rate, increase the stroke volume to overcome this hypotension. But actually, IV anesthetics will decrease the ability of the heart to compensate for the hypotension that is caused by the venodilation. So the baroreflexes increase the heart rate, increase the inotropic and chronotropic effect of the heart is decreased by the IV anesthetic. So when you give an IV anesthetic, the patient's blood pressure will decrease, and you will see an increase in heart rate, like when you give a propofol, as a compensatory mechanism for decreasing blood pressure. But this increase in heart rate will not be as increased as usual, okay, as it would be in other conditions when you are not giving an IV anesthetic. So the baroreflexes will be blunted to some degree with the IV anesthetics, okay? The blood pressure will decrease when you give IV anesthetic, mostly due to the venodilation, and in small amount due to the direct cardiovascular depression, okay? The heart rate when you give IV anesthetic will increase due to what? The decrease in blood pressure, but this increase in heart rate will not be as much as expected, okay? The contractility of the heart, again, it will increase due to the trials of the heart to compensate the decrease in blood pressure, but it will be not increased as usual. The preload, of course, will be decreased, okay, because you dilated, you are dilating the veins. The same amount of blood is in the veins, and you are dilating them, so less preload. This is the most important mechanism in hypotension when you give an IV anesthetics, okay? So when we talk about the direct or the effect of the IV anesthetic on the cardiovascular system, you must always be careful to certain group of patients who has more tendency to cardiovascular system effects more than other patients. These patients who has certain conditions needs a special care, okay? Like what? Like the patient with already cardiovascular diseases like heart failure, for example, valvular heart disease, arrhythmia, cardiomyopathy, and so on, okay? Or patient with bad fluid status, patients with major bleeding, for example, hypovolemic shock, or so on. this patient will be more prone to hypotension due to the IV anesthetics. And the reason behind that let's assume this is this cup is the vascular system of the patient, okay? In normovolumic patients, you will have this amount of blood, for example, and you, if for example you add 20 milligram propofol, okay, it will occupy this cup, okay? But with a concentration which is 20 milligram propofol over the amount of this blood, okay? But in hypovolemic patient, if you add 20 milligram propofol, it will have more concentration because you're dividing 20 milligram propofol over a less amount of fluid, okay? So the hypotension due to IV anesthetics in hypovolemic patients will be more pronounced, okay? So you have to decrease the dose of the IV anesthetics in bad fluid status patient or cardiovascular system disease patients, okay, or patients with neuropathy like diabetic patients. The diabetic patients are less capable of compensate for the hypotension because of already blunted baroreflexes due to autonomic nervous system neuropathy due to diabetes, okay? So also we have to be careful for patients with diabetes who have neuropathy, especially in the autonomic nervous system, or patients with autonomic neuropathy due to any other cause, okay? So the central cardiovascular system disease, fluid status, neuropathy, and the speed of drug injection. When you inject your drug slowly, the effect on the cardiovascular and the venous capacitance on these systems will be less pronounced, okay? So the hypotension will be less if you give your drug slowly. So always in elderly, in patients with these conditions, you have to give your IV anesthetics slowly, okay, so that you prevent the severe hypotension that may happen, okay? So elderly patients, okay, of course elderly age group will have more cardiovascular depression effect, okay? So in veins, we talked about what happened to veins. Now drug is in the right atrium and to the right ventricle, and from the right ventricle into pulmonary artery to the respiratory system. What is the effect of the IV anesthetics on the respiratory system? Actually, when we talk about the effect of the IV anesthetics on the respiratory system, we talk about many things. The first thing is the tidal volume, the respiratory rate, the apnea, so the minute ventilation, okay, which is the tidal volume times the respiratory rate. The apnea, does the apnea happens with the IV anesthetic? CO2 response curve, the light anesthesia effect on the reflexes of the muscles of respiratory system. Now let's start one by one. The tidal volume of the when you give an IV anesthetics will be decreased, okay? So if you have a capnograph, you will see less tidal volume, okay? So if patient is not taking IV anesthetic, you will see this tidal volume, but if the patient is taking IV anesthetic, you will see less tidal volume, okay? And respiratory rate will also decrease after some time. First, it will increase slightly, okay? You will have a decreased tidal volume but increased respiratory rate to compensate this. But after some time, you will have decreased tidal volume and decreased respiratory rate and decreased minute ventilation. And actually, most of the IV anesthetics will cause a profound apnea that lasts between 90 to 120 seconds, okay? When you give propofol, for example, you will see decrease in tidal volume, decrease in respiratory rate, and the profound apnea that will last for 30, 90, or 120 seconds depending on the patient, on the dose and the condition you are having, okay? Now the third thing or the fourth thing is CO2 response curve. In normal patients, when you have an increase in CO2 levels in your blood, okay, you will have a compensatory increase in respiration, okay? But in patients with IV anesthetics, who is taking IV anesthetic, this reflex will be blunted, so there will be rightward shifting of the CO2 response curve. So this is normal patient, and this is patient who's taking IV anesthetics. Normal patient, if CO2 increases, you will have increase in respiratory rate and tidal volume. Okay, but in patient taking IV anesthetics, you will have less increase in tidal volume, respiratory rate, less response to increase in CO2. So CO2 response curve will be deviated to the right side. Okay, now one of the most important things when we talk about the respiratory effect of the IV anesthetics is the airway reflexes and the spasm. The bronchospasm, the laryngospasm is one of the most important complications of the IV or of general anesthesia in general, which I'm going to talk about when I talk about the complications of anesthesia. Actually, to talk about it briefly, we have many stages of anesthesia. It moves from the analgesia, this first stage of anesthesia, then to the light or to the excitatory phase of anesthesia, and then to the surgical phase of anesthesia, which have three plans: the light, moderate, and the deep anesthesia, and after which the coma. Okay, one particular stage of anesthesia is dangerous in terms of that it increases the reflexes in the body, it increases the heart rate. It's an excitatory phase. Okay, the light phase of anesthesia is an excitatory phase with increase in the heart rate, increase in some myoclonic movements of the patient, okay, and increase in the reflexes of the airways. So if in light anesthesia, when you give an IV anesthetics, the patient will have increasing in the airway reflexes. So any manipulation of the airways, if you, for example, try to put a laryngeal mask or to intubate your patient in light anesthesia, you may have a laryngospasm, for example, or a bronchospasm. So the IV anesthetics, when the patient is in light anesthesia phase, will be associated with increased risk of a broncho or laryngospasm. Okay, and actually this is not a direct effect of IV anesthetics in most cases, but rather it is a effect of the light anesthesia that is caused by the IV anesthetic. Now the sensitivity of airways will also increase. Some of the IV anesthetics will increase the secretions, okay, and this will lead to, as I mentioned, laryngospasm or bronchospasm in certain cases, like ketamine. Okay, ketamine increases secretion of the respiratory system. So this is the effect of the IV anesthetic in the respiratory system. So now let's get back to our journey from the veins to the heart, right atrium, left atrium, to the pulmonary artery, and from the pulmonary artery to the pulmonary veins, okay, back to the left ventricle, okay, and to left atrium and left ventricle through the mitral valve, and then to the aorta. From the aorta, the IV anesthetic will go to the other systems of the body. Okay, the first system and the most important system when we talk about the pharmacodynamics of the IV anesthetics, the target organ of the IV anesthetics is the central nervous system. Through the brachiocephalic, the carotid arteries, it will go to the brain. This is the brain of your patient, okay? The brain. Now, what is the effect of the IV anesthetics, or most of the IV anesthetics, on the central nervous system? When we talked about the effect of the IV anesthetic on central nervous system, the first and the most important thing that we talk about is the effect that we want, the sedative hypnotic effect, okay, which is dose dependent. At low doses you will have sedation, at high doses you will have hypnosis, okay? And when we talk about the central nervous system effect of the IV anesthetic, we talk about some terms like the potency, the efficacy, and the effective concentration range. Actually, there is a huge variability between patients in terms of IV anesthetic effect, like sedation and hypnosis, okay? And this variability made the concept of a concentration range. You can't give a certain number and say this is the sedative dose for some IV anesthetic, or this is the hypnotic dose of the IV. You have to give a range, a therapeutic window, because each patient has different, okay, number other than other patients, okay? So this is why we talk about effective concentration range. Now there are two concepts, the efficacy and the potency, and actually they are similar, not the same, but have pretty much similarities. The efficacy of some drug is the maximum effect that you can have of this drug. For example, the maximum effect that you can get from propofol on the EEG is silent or burst suppression of the central nervous system, okay? But the maximum effect of benzodiazepine will be less than that, okay? Most of benzodiazepines will not cause burst or isoelectric EEG. So the efficacy of propofol on this point of view is more than benzodiazepine. The potency of some drug is the maximum dose that you can you have to give to get some effect, okay? So if you, for example, in case of propofol, the sedative dose will be, for example, 10 milligram. Benzodiazepine, midazolam, the sedative will be, for example, 2 milligram, not 10 milligram. So benzodiazepine may be more potent than propofol. This is just an theoretical example, just to understand the term of potency. Okay, so the sedative hypnotic thing is the first thing we talk about when we talk about the central nervous system effect of the IV anesthetic. The EEG, the intracranial pressure, the cerebral metabolic rate of oxygen. Actually, let's move to the cerebral metabolic rate of oxygen and intracranial pressure. And these two things are very important when we talk about neurosurgical patients. Okay, the cerebral metabolic rate of oxygen will decrease when we use most of the IV anesthetic. So the brain will use less oxygen to do the things that it's usually doing. Okay, so cerebral metabolic rate of oxygen will decrease, which will give some protective effect on the central nervous system. Okay, and the intracranial pressure will decrease also. The intracranial pressure will decrease due to many causes. One of them is the hypotension or the effect on the mean arterial pressure. Okay, it will decrease due to the venodilation, as I mentioned before, and also the IV anesthetics will cause a vasoconstriction on the cerebral blood supply. Okay, vasoconstriction. This vasoconstriction will decrease the intracranial pressure. So the vasoconstriction and decrease in blood pressure will decrease in intracranial. And actually, decrease in intracranial pressure is something important in neurosurgical patients who has, for example, a trauma, tumor, subdural hematoma, or malignant or benign thing in their brain, and there is an increase in intracranial pressure. Any increase in the intracranial pressure will lead to a major complication like herniation of some brain tissues. Okay, so giving a drug that decreases the intracranial pressure and decreases the cerebral metabolic rate of oxygen will have a great benefit in this term. Okay, so the cerebral metabolic rate of oxygen, the intracranial pressure, and now the EEG. The EEG electroencephalography will be affected in different ways for each IV anesthetics, but in general, at low doses of IV anesthetic, you will have an increase in frequency of EEG. Okay, in frequency of EEG, but at high doses, after some time, you will have a decrease in frequency and increase in the amplitude, okay, of the EEG. At very, very high doses, you will have isoelectrical EEG or burst suppression of EEG when you give an IV anesthetics. Okay, so this is the effect on the EEG. Actually, some IV anesthetics are associated with seizure-like, or most of the IV anesthetics are associated with seizure-like myoclonic activity. Sometimes when you give a propofol, you will see some myoclonic movement of your patient, which is non-epileptic, by the way. Okay, non-epileptic. Some of the IV anesthetic is associated with epileptic-like myoclonic movement, which is associated with epileptic changes in EEG. Just like methoxetal, for example. Okay, methoxetal is associated with some epileptic activity. Etomidate in a previously epileptic patient will have some epileptic myoclonic-like activity. But propofol and most of the IV anesthetics, ketamine and other IV anesthetics, will have non-epileptic seizure-like myoclonic activities. Okay. Now, when we talk about the central nervous system of IV anesthetics, we sometimes talk about the protective effect of the IV anesthetics. As I mentioned, it decreases the intracranial pressure, decreases cerebral metabolic rate of oxygen. So the brain is now needing less oxygen to accomplish its missions. Okay, so that will lead, if you have a decreased blood supply to the brain or decreased oxygen supply to the brain, it will have less damage due to the decrease in the cerebral metabolic rate of oxygen. Other protective effects is due to the NAMDA